at Snohomish County Health Department. I work in maternal or children and family health, and I'm very excited about this topic. We're going to let me do something real here. We're going to hear about this is quarterly, so we talk about neuroscience, epigenetics, ACEs, and resilience. And we're going to talk about ACEs and perinatal mental health, supporting communities of color through culturally relevant care. And so I want to introduce our speakers and read their a little bit of their bio. Shakima or Kima Toze is a clinical military social worker, certified perinatal mental health clinician, certified diversity professional, and social worker doctoral student. She is focusing her research on BIPOC maternal health disparities, health equity, and policy systems change. Kima approaches her work and advocacy activities through the lens of diversity and intersectionality. As a bereaved mom, she advocates for families affected by perinatal loss, birth trauma, and infertility, particularly BIPOC, who are most burdened. In April of 2021, Kima and a team of bereaved mothers instrumental in getting legislation passed in Washington to issue the certificate of birth, resulting in stillbirth. She sits on the Washington State Maternal Mortality Review Panel and is a board member of Perinatal Support Washington. And we're really glad to have you, Kima.
It's great to be here.
And then I would like to introduce Maylene Velasquez. Is that how you say your last name? I'm sorry, I should have checked that out.
It's okay. You're close to Velasquez.
Okay. She is an immigrant Latina psychotherapist specializing in perinatal and infant mental health. Maylene has a doctorate in social worker and focused her research on anti-racist and anti-oppressive mental health services. Her work supports birthing people and clinicians working on practicing from an anti-oppressive framework. She sits on the Alliance for the Advancement of Infant Mental Health Board. She has served on the boards of the Washington Association for Infant Mental Health, the Florida chapter of Postpartum Support International, and the Florida Association for Play Therapy. She is an author and speaker who has presented at multiple national conferences and loves increasing awareness of the intersection of perinatal, infant, and child counseling services. Maylene identified as a brown person for most of her life until several years ago when vitiligo changed how she navigates the world. So welcome. We're really glad you're here, Maylene. Thank you guys for coming and presenting. So I'll let you take it away.
All right. Well, thank you so much, Sue, for that lovely introduction. Thank you, everyone, for being here on your afternoon on a Wednesday to kind of experience this with us. We just wanted to start with just some logistical things just to get that out the way so you kind of can spend most of your time taking in the information. We'll have a breakout session, or we'll have some interactive activity built in. First, I want to just say we have a lot of great content for you guys that we'll share today. If we could hold questions to the end, that would be best to make sure that we are maximizing our time together. Feel free to also use the chat. Sue's going to help us monitor the chat. And I'm on Teams. We're on Teams, and to be honest, I can't see anything. So Maylene is going to help me with just getting some interaction in terms of, our audience here, if there's things that I need to be aware of. But
hey, Kima, do you want me to hold the questions from the chat until the end?
Not necessarily. I think you can monitor it. If there's something that is coming up that's relevant to the slide, I think we should bring it up then.
Okay. Sounds good.
But in terms of us making time for questions, we'll hold that to the end. And then we just wanted to start with, if you could pop in the chat, tell us where in your world you're joining us. So where are you, and then what your role is in the perinatal mental health space? So as you guys are sharing who you are and where you come from, we want to just share a quote that really speaks to this work that we're doing. And it's from Michelle Obama. And she says, you know, we really need to do a better job of putting ourselves higher on our own to-do list. And we all know that that's true. And this universal statement from PSI also really highlights, you know, how important that is. And that statement is, you are not alone. You are not to blame. And with the right help, you will be well. So I'll just quickly go through this. Sue did a lovely job of sharing my bio and a little bit about me. Some things that you don't know. I am on the Preeclampsia Foundation Patient Advocacy Council. I'm also a member of Mama's Voices, and I'm a survivor, thriver, servant leader, tree hugger, and a goat wrangler. And yes, I do have goats. They are part of my healing journey. So yeah, I'm excited to be here with you guys today.
Hi, everyone. I am Maylene Velasquez. And I wanted to just share a little bit about who I am in terms of social location. Like Sue mentioned, I am an immigrant. I was born in Venezuela. And I'm a daughter of immigrants, so really a daughter of the diaspora. My maternal family is Cuban, and they're the folks that I grew up with, and my paternal family is Colombian. And I have we call them in Venezuela tajadas, but they're plátanos, plantains, because I'm fully Caribbean, and so that's an important part of who I am and how I navigate the world. Something important also about me in terms of social location is, if you didn't catch that last part that Sue was sharing, I have vitiligo, which is an autoimmune condition where the cells in your body, your immune system, attacks the cells that produce melanin. For me, it developed when I was 16 with 2 tiny little spots, and it just sped up exponentially when I was around 27, 28 years old. And it shifted how people see me. And how I navigate the world, right? So as I step into, I'm stepping into my 40s, and I'm owning my brownness and connecting with my heritage, I have to recognize that it's a brownness that I carry on the inside. You might see it if you see me in person, but it's not. It's kind of, when we think about identity, some of the identities we carry on the outside, and some of them others don't know until you mention, usually until I open my mouth. But yeah, just happy to be here. We can go to the next slide. We have this as a placeholder. Just what we're hoping to do today is really to provide some information which will be useful and helpful in your practice as you serve pregnant and postpartum people, and to give you some tools that you can start implementing in your work. Keep in mind, I have expanded and done versions of this presentation multiple times, and each time we're thinking about how to better it, how to make it more attuned. So we hope it's useful and helpful. We can go to our mindfulness slide. Oh, hi, Abby. Thank you for being here. So we wanted to start with just a brief groundedness and an invitation to mindfulness. And I also want to, maybe even before we do our invitation to mindfulness, I'm going to do a land acknowledgement. I'm going to do the mindfulness, and then we'll move into our presentation. If you're here with us and you have your sound on, I'm just going to invite you to turn your mics off. And this is a very selfish ask. I have a neurodivergent brain, and so any sounds, any movement, and I'm lost. And so it's a selfish ask. Yeah. So let me kick us off with our land acknowledgement. So acknowledging whose land we're in is a meaningful way to show recognition and respect for Indigenous peoples, as well as taking a step towards resisting erasure of history. However, a land acknowledgement is maybe a starting point, right? It's a small step. And it becomes meaningful when we really think deeply about how are we learning about history? How are we learning about local treaties? How are we learning about how those treaties were broken? How we're learning about practices, how we're building relationships, and how we're really thinking about what it means to us to remain accountable. Accountability is going to look different depending on where we are on an anti-racist, anti-oppressive journey. But I invite you to think in this moment what accountability means to you. So I am on the stolen land of the Coast Salish peoples, and I ask you to join me in acknowledging the first people of Seattle, the Duwamish people. We acknowledge their people, stewardship of the land, elders of both past and present, as well as future generations. I was also born on the land of the Timotes people. I also invite you to hold the Timotes people in mind and to honor um, elders that have protected the land, generations that will continue to protect the land and that have been here and will continue to be here. If you want to share with us whose land you're coming in from, feel free to drop it um, in the chat if you haven't.
Maylene, can I just ask if the slides will be available later on for people to look at?
Yes, absolutely. I think, Kima, did we provide the slides? I think we
We
did. Yeah.
did, but we had made some changes. There's some tweaks,
Okay.
so we can provide an updated
Okay,
PDF.
thank you. Thank you.
Thank you. That is a good question. Okay. So with any time that we're coming into a space to ground anti-racism, anti-oppression, when we're talking about the lives of perinatal people, we recognize that these are not the stories of some some folks that are over there. These are our stories. This might be our life experience, whether it is what we went through, what we're going through, what was somebody that we love and care about is going through. And so, as we lean into reflection, I'm just going to invite you into a moment of mindfulness. And this is an invitation. Feel free to lean into it as little or as much as you feel comfortable with, which is the invitation for the rest of our time today to take care of yourself. So, if it feels safe and comfortable for you, I'm going to invite you to just notice your body and the space that you're in. You can take a couple of deep and intentional breaths, and you can follow what feels attuned to you. That might be breathing deeply through your nose and exhaling through your mouth, or it might be exhaling through your nose, whatever is attuned to you. I invite you to notice the places where your body might be holding some pressure. This might be where your hands are resting. It might be how the seat beneath you, supports your body. It might be where your feet are resting. And take another breath. I invite you to notice any sensations. This might be the temperature of the space that you're in. It could be paying attention to how the clothing feels against your neck, the clothing that you're wearing, how it feels against your neck, your shoulders, how it feels against your arms. When thoughts come up, which they often do, just invite you to name them and see if you can go back to grounding either on the breath or the sensations that you're feeling. I'm going to invite you to take 3 deep breaths as I share this quote, which is actually a series of questions from Ruth King, who is a um, social justice advocate, meditator. And Ruth says we must be clear in our intentions regarding what we want to wake up to, and then attend to those intentions mindfully. We all need an intention beyond righteousness. Ask yourself, what is your vision of racial healing? Why is this important to you personally? What do you need to face up to and own in order to stay awake to racial suffering? And how will this benefit all beings? When you're ready, if your eyes are closed, you're welcome to open them and just reorient to where you're in. And hope that the rest of the content is useful. We'll move on to the next slide. I'm ready. My grandma used to say LPV, which is an acronym for, in Spanish, Lista para Vencer, which is like ready to conquer. So I'm LPV. So we're going to begin with ACES, trauma and well-being, and I'll go through this section fairly kind of smoothly fast, since we're most of us are grounded on ACES. We can go to the next slide. So this is just my little messy visual of how I think about the field of mental health, but really any field that is a service field. Where at the center we have, you know, this foundation of systemic racism that impacts everything that we experience, everything that we connect, everything that we hear, everything that we learn. At the sides, you have licensing bodies. So this can be for me, it's the social work association. It could be the Department of Health. It can be, if you're a nursing professional, it's the organization that allows you to be a nursing professional, or whatever industry you're in. Then we got national organizations like the National Association of Social Workers, the National Counseling Association, the American Medical Association. We have academic programs, which could be where we went to school, where we learned. It could be a training like this one that we're doing. And we got the field of academia, which encompasses research. And all these four bodies, right, not only are they informed by systemic racism, but they have two goals, right? And the goals are, one, financial sustainability, which I think is a lifelong goal for most of us because most of us have bills to pay. And, you know, this is part of the capitalistic system that we live in. If there's no financial sustainability, then we can't provide services. And then we have patient outcomes, right? And I think that this is where sometimes intention can separate from action and what's actually taking place, right? We want clients to do well. We want the community to do well. But without that anti-racist lens, we might fail to see how systemic racism impacts, right, all these pieces. We can move to the next slide. Sorry, I'm also not used to Teams, and I clicked something and everything disappeared, but it's back. All right. And so the invitation here is to constantly, as we're thinking about perinatal folks, as we're thinking about our work, to really expand the view, to think about the individual that we're working with, the community in which that individual is at, to think about the society, right? And this can be, right, the culture that the person's in, and all that culture encompasses. It's looking at the city, the state, the nationwide laws and climate, right, that impact how people navigate the world. Because I know that for me, right, in mental health, I was really taught to think about pathology residing inside the individual, right? And our invitation through an anti-oppressive lens is really expanding that vision to recognize that pathology exists within the system, right? And it links back to systemic racism, structural racism, right? And it impacts outcomes for everyone, right? Because nobody comes out unscathed on this, especially when we think about Black and Indigenous individuals. Next slide, please. And so here we got the ACEs, which are all familiar with. We got abuse, neglect, and household dysfunction. And then I wanted to include the urban ACEs, which are on the next slide, which expand a bit of our lens of how to understand the adverse effects that people are having as they're navigating the world. Kima, can we go to the next slide, please? And so we have this Philadelphia study group, or the research committee came together and um, we're addressing witnessing violence, and this can be community violence, the felt and experience of discrimination, neighborhood experiences, being bullied, and residing in foster care. I often share here as an immigrant and somebody that has been in counseling since I was able to go to college. I think about a question that people often didn't ask me is, what was my life like when I was residing in Venezuela? And then I think about the amount of violence that I grew up with. Not only I'm somebody that has 10 plus ACEs, but not only the violence that I experienced in my home, but also the violence that I experience in my neighborhood, right? Like the fear of constantly being kidnapped, the threat of being kidnapped, the attempt of being kidnapped, the hearing someone screaming and looking out the window and seeing a horrific scene, right? As a 6-year-old, a 7-year-old. Right, and I share this because the invitation is always to be curious about what we're not asking and what we might need to know more of. And then not only why are we not asking this? Why do we need to know more of it? But what are we going to do with this information? And how do we allow it to inform our practices and how we support people? Next slide, please. Right. And here is like the why, right? That at the beginning of what impacts early death from the moment that we're born is that intergenerational transmission of trauma. I used to think that the first ACE that a child experienced was untreated mental health of a caregiver. And with training, with listening, with learning, with doing my own work, I've really learned to recognize that the very first ACE is that embodiment of historical trauma that children are born with. Or, language matters. So I said that children are born with, but that systemic racism, right? The embodiment of trauma is not because children are, it's not children's fault, it's not parents' fault, right? It's a systemic issue. Next slide, Kima, please. Right. So when we think about perinatal mental health, we're thinking about the period between pregnancy and up to 2 years after a child was born. I have this slide here because we want to think about the slew of complications that can happen when somebody is experiencing a mental health complication, right? Like comorbidity is the norm, and it's the norm, right, in part because of the society that we live in. So I invite you to think of depression, but also to ensure that you're screening for all the other complications that may be present. Next slide, please. All right. And so here we have, right, that first ACE is that the history, right, what we're bringing into our DNA. I think that's it for this first section. Back to you, Kima.
Yeah, thank you, Maylene. So we're going to dive into the perinatal mental health in communities of color, more of like looking at statistics. Many of you already know what those statistics look like, but we want to talk about like their impacts and get a little deeper with that information. We know that BIPOC people from marginalized backgrounds may face major difficulties in obtaining mental health services. But for folks that are perinatal, across that perinatal period, they may suffer even more physical and psychological challenges. And so we want to be thinking about the social determinants of mental health, those early traumatic experiences, a lot of what Maylene had mentioned earlier about someone's cultural experiences, the things that they've gone through growing up. But then there's some other cultural understandings that we can start to have a better awareness of. So in the next few slides, we'll look at some of the numbers. So while 1 in 7 women report experiencing perinatal mental health complications, almost 40% of Black mothers and birthing people experience maternal mental health conditions, making them the majority of the affected group. It's also important to note that single Black mothers are 6 times more likely to experience depressive symptoms compared to the general population. Studies have also shown that there are racial and ethnic disparities in accessing postpartum depression treatment, particularly for low income Black and Latina women having lower rates of initiating treatment and actually continuing the treatment. And so this disproportionality really does highlight the need for further research in this area and to better understand what are the barriers that these communities are facing so that we can have a better sense of what are some culturally responsive interventions that we can develop to help reduce these disparities. So we also know that maternal suicide is the #1 leading cause of death in the first year of postpartum. And that accounts for 20% of deaths. Um, Women of color have higher reports of suicidal ideation during the postpartum period. So going back to Maylene's question, are you asking about suicide? Are you asking those important questions? So mental health complications also contribute to nearly a quarter of all pregnancy-related deaths. Almost 30% of American Indian and Alaska Native women experience maternal depression. Indigenous women face the highest rates of drug-related deaths and suicides during pregnancy compared to other racial groups. And it's also critical to note that further research on some of the barriers, like we mentioned earlier, and for BIPOC and other birthing folks in the US seeking care is something that we have to continue to look into to find out what is causing this disparity. So I'm just curious for the group, are you surprised by any of these numbers? If you can add in the chat, what thoughts or feelings are coming up for you as you see these statistics? Does anything surprise you? And I'll just pause here if there's any comments. Sue, I'm not able to see the chat if there's anything coming in.
Jenny's, whoops. Not surprising, unfortunately, but makes me feel angry and sad. It's Jenny with the arc of
Yeah,
Spanish
not
colony.
surprised. Yeah, not surprising is the key thing, right? When I saw this, I thought, I kind of know this already, but it's sad, right? It is heart-wrenching. So we do need to really think about how can we get the disparities to eliminate those.
Mm.
Okay, so mother-baby health impacts. This is another really important and critical issue, and something that I'm really fascinated by. So the effects of a mother's trauma, particularly racial trauma, has a profound impact on the health of her baby. And this is demonstrated through studies by the Centers of Disease Control, which show that Black babies are twice as likely to die during or shortly after birth compared to babies of other races. And furthermore, the research has also shown that Black doctors provide care for Black babies actually can extend the life of the survival rate of those babies. And I'm thinking, why is that, right? So many of you may have heard of this term called weathering. So there's a public health professor, her name is Dr. Arlene Geronimus, And her research is, she did some research on the, how Black women in their fertility and how that impacts their health. And so she developed, or she coined the phrase weathering, the weathering hypothesis. And basically, what the weathering hypothesis says is that the health of Black women may begin to deteriorate early in adulthood due to these cumulative socioeconomic disadvantages, which can lead to preterm labor and it can lead to maternal mortality. And so, there are studies out there that show that BIPOC women often face mistreatment as well in the healthcare setting. And a lot of it's based on their race or their ethnicity. And so, some examples that you may have heard of is this national study that was done from 2016 to 2017, and it's called the Giving Voice to Mothers study. And what this study found is that 1 in 6 pregnant individuals said that they were mistreated during their childbirth. Um, and these systems that Maylene had talked about, right, in healthcare systems and other settings where they're going to get care, and so that's really startling. And so these findings really help us call to action that we need to really eradicate some systematic discrimination and racism issues that we have in healthcare, and we also know they present as well in mental health care as well. So um, and then worst of all, they put, our BIPOC moms and babies at higher risk. Okay, so the World Health Organization states that a person's mental well-being and the risk of developing certain disorders impacts their social, economic, and physical factors. We know that inequities in resources and opportunities exist for different groups in our society. We're no stranger to that information, and that these disparities lead to further divisions in our society, right? And so the social determinants of mental health is a framework to be thinking about in your practice as you come across, the folks that you serve. Be thinking about what are some of the social determinants of mental health factors that make up their lived experiences. And some of those factors can be social issues like racism, child abuse, discrimination that they've experienced. It can be intimate partner violence, economic difficulties that they may be experiencing. Maybe they don't have a job or they're underemployed. It could even be housing quality issues. Maybe they are living in a really substandard community or housing situation. They're exposed to pollution and just really horrific living conditions. They may be homeless. We know our homeless population is continuing to increase, right? It could also be structural issues like their cultural values that can shape their mental health experiences. And we also know that systematic policies that we have in place in our society can really um, hinder someone's ability to have good mental health. And so we'll talk a little bit about that later in the presentation, but I wanted to just set the stage for this idea of social determinants of mental health. And so this is a nice visual again about the social determinants of mental health. And if you could look at this in the way it's portrayed here, it's in, if you look at 4 broad buckets of, let's say, issues, right? Things that people might experience. Um, if you can think about your own clients that you serve, right? And some of the factors in these buckets they may be experiencing, but as professionals, sometimes those things are not always on the top of mind. And I'll be honest, I've had experiences, for example, a client doesn't show, or maybe it's like the third time they haven't shown and they don't pick up the phone and you're wondering, well, why they're not coming in for treatment. And you might think they're not serious about care, right? They don't really want to be here. They're just wasting my time. But there may be other factors going on for them. Like maybe there's a transportation issue. Maybe they can't really take off time from work because they can't afford it. Maybe that third session really can financially break them, right? And so coming in for a third session with you, although they know they really need the care, um, they have to make life decisions that may not always be in their best interest, but it can help them survive and keep going, right? So, taking this step further, you want to be thinking about, well, what are some of the biases that I might hold um, as a practicing professional and I'm serving my community, that, how am I judging others? How am I judging my clients? And being really mindful of that and thinking about, you can use this as an assessment tool. Are there buckets that I haven't even thought of because I didn't ask those questions, like Maylene said earlier? I didn't really find out, what's really going on with this person. Or maybe they haven't really revealed that to me. Maybe they didn't share, hey, I'm in it, I'm dealing with domestic violence at home. Um, so just digging deeper and being more curious, not assuming, and asking those questions is critical.
So we're going to think a little bit about embodying cultural humility. Let's go to the next slide. This comes from my research. I mentioned I did a doctoral program, and my work focused on looking at cultural humility and how it shows up in perinatal social work. So I have some lessons I'm going to share briefly, and I'll share like the toolkit of my study in an email so you can look at it more deeply. I don't want to take too much time on that. Um, so I'll share in general terms. The first call is to really look beyond competency. Humility entails that we're not going to know, and we're not supposed to know. And sometimes I find that when we get into conversations as a group and then we're thinking about our blind spots and the things that we don't know, the conversation can quickly shift to, well, how do we know? How do we, have all the information? And so we want intentionality around continuous self-examination and critique, and centering the person as the cultural expert, right? And that can't happen unless we're really taking a step back. The next step is to really look at how we are implementing an anti-oppressive way of being, where we're engaging in learning, recognizing biases, being aware of our social location, being mindful of ethnocentrism. It's always going to be present, it's always going to be in the mix, right? It's our capacity to recognize when it shows up. And that when we see it, then we can take action on removing the barriers that create harm. I want to invite all of us to think about what our foundational practice skills are. And if we know our foundational practices really well, then right, we can notice where, right, if we go back to how systemic racism, right, impacts foundational knowledge and skills, we can recognize where it's showing up and then work with communities, work with, right, the people that we have around us to shift the system. And then we want to address training challenges. We want to like know who we are learning from, and what sources we're going to for learning, because it matters and it makes a difference. And if I want to learn about Afro-Latino trans folks and how to support perinatal care in Afro-Latino communities, then I have to go to the source and learn from Afro-Latino trans communities who are doing the work and pay them for the labor of teaching me. Let's go to the next slide. Um, and so as we think about, expanding cultural humility into a lens of healing and liberation, this is the, moving it from like up here where we have the knowledge to like heart and soul, or however you think about heart and soul. What are your values? How do you connect with meaning? What gives your life meaning? Because if you know yourself deeply, if you examine your values deeply, then, right, you can look and challenge and then protect the land, right? Our relational worldview is the path forward, and the path forward is through indigenous ways of knowing. There's nothing new under the land, right? There's nothing new in the world. But what we need to do is know, recognize when we need to take a step back and, right, close our mouths and not be the one centering ourselves, but like really learning and
Is this?
listening. Oh, did I hear someone?
Yeah. If could we all mute ourselves, please?
Oh, thank you.
Thank you.
And so I want to share, right as I transition out of, heart and soul, and heart and soul is lifelong. This is not something that we're going to accomplish, right, in a 90-minute being together with folks. This is not something that we're going to accomplish in 5 years of work. This is lifelong, so that we can continue to build pathways for each other. I have a poem, prose that I want to share from a book called Inward, and it's by Yung Pueblo. And I think it exemplifies his heart and soul. Yung Pueblo is his pen name. His name is Diego Sanchez. And he says, I can only give to you what I have already given to myself. I can only understand the world as much as I understand myself. And so I leave you with that and pass the mic back to Kima.
I really love that. I was actually thinking it would be a little longer of a quote, so I think it's so succinct but so powerful. Thank you for sharing that. So yeah, we're going to dive a little bit deeper into applying equity and belonging to the work. But I wanted to sort of set the stage because we're sharing a lot of different words and vocabulary that you may have been aware of. Maybe this might be the first time you're hearing about it, or trying to understand what these words mean. And so I just wanted to say a little bit about culturally responsive care. So culturally responsive care is a philosophy that values and respects all aspects of the individual's identity, their background, experiences, as well as their experiences in mental health treatment. And this is an approach that helps individuals, whether it's LGBTQIA folks, BIPOC communities, or folks from other underrepresented groups, to really feel safe, to feel understood and accepted, to experience mental health being accessible to them, um, and to really have like really culturally congruent experiences with care. And so we know that culture plays a significant role in shaping how we believe things in the world, our behaviors. It shapes our interactions with each other. It also impacts how we interpret, how we feel. So when we think about mental health experiences, our culture will affect or influence how we think about depression, or what is depression, for example. What is anxiety? In certain cultures, there may be a name for that, or there may be no name for it. There may not be a blueprint on how to cope with those symptoms. So just to be thinking about that in terms of being culturally responsive to who's in front of you. Um, Another word I want to make sure that we have a basic understanding of is equity. And in equity, it really means that all of us have full and equal access to opportunities that enable us to really have our full and experience our full potential in life. Um, Belonging is another word that we had talked about. It's in our title of this presentation. And so I wanted to pull a definition that I found from Cornell University that I really like. And it says that belonging refers to the sense of being welcomed, accepted, and valued as a member of a particular group. It also encompasses feeling this sense of security, feeling like we have support, and that we have a sense of inclusion, and that we are being recognized for our identity within that group that we are a part of. So we are really being seen for who we are individually within that group that we have a sense of belonging to. And so when we're in our therapeutic spaces, how are we creating a sense of belonging for clients, right? How are we creating equity? Um, And how are we being culturally responsive? Some questions to be thinking about. So, if you're wondering, well, how would I apply equity to the work? What would that look like? Well, it would look like, you know, looking at factors that are not just one dimensional. So, from an equity lens, you would look at individual factors that can impact someone's engagement and care, for example. So those things can be, well, what are their attitudes and beliefs about mental health, right? What are the relationships that they experience in their lives, right? Do they have a support system? And if then, what is that support system? How do they show up for them? And does that support system believe that mental health is actually a thing? They may have a support system that doesn't even believe that mental health exists. Um, it can also be factors like their physiological existence. So, them as a person, how their body works, their body chemistry. We're all unique as a fingerprint. So, what does that look like for each person, right? How do they show up in the world? And I think Maylene's example of her experience with vitiligo is a great example of someone's physiological makeup and how that makes them very unique. Also, systems of power factors, right? So we know that we have policies and structural um, conditions in our society that don't benefit every single person. So if I were to give everyone in this audience a pair of sneakers, size 8, for example, not everybody would be happy about that because it's like, okay, maybe you're a size 10, so that would be a waste, right? Not everybody can benefit from a size 8 sneaker, even if it's cool, it's brand new. So we all don't, even though we all may get the same things, we all don't need the same things. And so it's important for us to know those differences. And when you work with your clients, you know that each person is very unique. They're their own person. So what is it that they need? And that really pulls you out of the cookie cutter approaches to care, right? Because not everything fits every person. So I love frameworks. So this is a framework from ETR. ETR is a nonprofit organization, and their mission is to advance health equity for youth, families, and communities. And so they created this health equity framework that I use in my practice and I use in my research um, to really help us have a framework to use when we're thinking about how do I apply an equity lens to what I'm doing and how I'm showing up. And so this might look like a lot, but let me just break it down to you. So the health equity framework is so in that middle there, that's the health outcomes. That's the things that we want to see change, right? The positive changes. But we also know that health outcomes are not always positive. And each of those circles around that health outcome circle are categories or areas that we can be looking at to see how equity is being manifested. Is it hindering a person's health outcome, or is it actually advancing and furthering their health outcome so they can reach their fullest potential? And so, if you use this framework as a self-reflection tool, you can go and you can see as in each question. For example, if we were to look at someone's relationships and their relationship networks, right? These are the support systems, the people in their life. If you were to think about a client and ask this question, beyond the individual, beyond that client, who has influence over this outcome, right? Who has influence over them showing up for their appointments with you and engaging in care? And you might think it's only their responsibility, but they may have other people in their lives that influence their engagement that you don't even know about. And so that next question is how do or could families, friends, partners, or other support systems support better outcomes? How can you engage their support system to help this person engage in care? help this person make it to their appointments if transportation is an issue. Um, and then that last question is, how do relationships with others enable harmful behaviors or create barriers to better outcomes, right? So going back to that example of that intimate partner violence, right? Maybe there's some barriers, some things going on that make it difficult for this person to engage in the care that's helpful for them to have better health outcomes. And so each of those areas, we can ask similar questions to get a deeper understanding of how equity might be showing up for that particular person and why that their experience with equity might either be kind of a negative experience that's hindering their ability to have equitable mental health support, or it might be advancing that. So, okay. So another approach to this that I want to talk about is this idea of co-designing solutions. And so we know that culturally responsive care honors individuality, right? And it really involves having diverse folks at the table to have a voice, to be heard, like Nalene said earlier, going to the source, right? Asking the folks that are living it to share, to provide input, to get feedback. And so co-design is a approach to research, it's an approach to designing products. Um, it's the approach to designing programs as well. So it can be used not just in mental health care, it can be used across different disciplines. But the idea of it is that the work is not being done alone. So it's not just a table full of mental health therapists deciding, okay, what kind of care do we need for our mental health center, right? It's saying, hey, let's let's invite some of our clients or past clients to give us some feedback on what experience they had with our services and what sort of programs would be helpful that they can help us, you know, put together and design and get some feedback. So that's what co-design is, and it's a different, innovative approach to really having programs be useful, right? So going back to this example of the sneaker, right? So if I gave you some sneakers and it's like, I don't even like these sneakers, you know, I gave you Nikes and you wanted Adidas. And I never asked you that. I just gave you what I thought you needed. We know that that never works. So, so this is another approach to inclusivity and building a sense of belonging in your practice. And then just one real quick note I wanted to mention is that there's several ways that you can incorporate co-designing. Some quick ways that I want to share, things like your intake process, you know, looking back and thinking, well, how helpful is our intake process or our paperwork? Is our paperwork linguistically and culturally sensitive, right? Are we considering a spectrum of people who might need our services? Or are we only thinking of, you know, one type of demographic that we are serving? Um, are we set up where we can have translation or interpreter services be available for someone that needs them? How flexible are we with making changes to our policies so that they are inclusive and they are considering cultural experiences across the board? So I will transition now. I'm going to stop talking, but we have a case study that we wanted to present to you guys to get a feel for looking at some of these issues and dynamics that we talked about. So looking from a social determinants of health lens, looking from an equity lens, we want to share a case study so that you can get some practice with this, and then talk amongst your group of like, yeah, what do you think about this experience for this person in a case study? We have some questions for you. So I'm going to transition to the case study. If I can just get one volunteer from our audience. Again, I can't see you guys, But if somebody is, we have a brave soul that can read the case study out loud, and then Maylene and I will kind of direct how this is going to go. So I'm going to share my next slide, and if we can have someone that's willing to share, to read out loud this case.
I'm fine with going. Oh, sounds like do you have? Should I go? I want to make sure I'm not cutting off somebody.
Sounds like you got it.
All right. So meet Barbara. Barbara is a 45-year-old Black woman and survivor of childhood sexual abuse and intimate partner violence, who was admitted to the hospital for an emergency C-section following concerns with the baby's heart rate. Barbara is diagnosed with HIV and has been receiving perinatal care at a clinic that provides care to women who have HIV. She shared that she was in the hospital to complete a stress test, which was mandatory due to her age. Barbara shared that she felt desperate and scared when told that she needed to have an emergency C-section. She expressed having contacted family members who attempted to have her transferred to a different clinic to no avail. Barbara stated that she was treated like a number and had experienced the medical staff talking about her like she was not in the room. She stated that she had to spend the night at the hospital and had multiple shifts of professionals with whom she attempted to share that she should not be having a C-section due to her medical condition. She shared traumatic experiences such as a doctor massaging her cervix without using lubrication and not receiving proper postpartum care. She delivered her baby at 4 pounds, 13 ounces, and was separated from her for 1 week until she signed to take her baby against medical advice. Is there more?
Yeah, that is it. Thank you.
Okay.
Thank you so much. What's your name?
Jesse?
Jesse. Thank you, Jesse, for sharing that, for reading that. Okay, so I'm not able to see how many people we have to get into groups.
Right now we have 26.
Okay. So do we have a math person in the room? I don't want to embarrass myself.
I have a calculator handy. And we want like 4 or 5 people.
Yeah, so maybe 4 people would be ideal.
Okay. So I'm gonna do, that's 6.5. So I'll do 6 breakout rooms.
Okay.
Okay.
Right. So as Sue is doing the breakout rooms, I want to show you guys the questions that you'll be reflecting on. And if you want to jot them down, because I'm not sure if we can put them in the chat for you. But the questions are reflecting on the barriers that Barbara has experienced. What went wrong with her care? And then we want you to identify the social determinants of mental health factors that could be impacting Barbara's health. And then we want to we're asking you what could have been done differently in Barbara's care from an equity and belonging lens.
I added the case study and also the questions to the chat.
Oh, wonderful. Thank you, Maggie.
All right.
So,
sorry.
Sorry, I was going to say, once you're ready to go, we'll give you 20 minutes. So just let me know when you're ready to put folks in groups, and then I'll set the timer.
Okay, I think I'm ready. I've never done this, so hopefully this will work.
Okay.
there 4 people on here? Hello? Hello?
Hello?
Can you hear me?
Yes, it's cutting in and out, but I hear you.
Sorry, yeah, I'm hearing and then I'm like driving, so I'm like,
Oh,
but, okay. Well, I think we have 4 people on here then, right?
I believe so. I had to log out and log back in because I was in a room all by myself for a while.
Oh, weird.
I was like, what's going on? So,
Okay.
oh, oh, I'm sorry. I don't know if you can hear me, but it's really cutting in and out. I can't hear you.
Yes, I can hear you. Sorry.
Oh,
Like
good.
kind of confused.
Yeah, it kind of goes in and out.
But you can hear. Yeah, I don't know.
Maybe we can do, oh, you're driving, so we can't do the chat. Yeah. Let's see. Um, there we go. Okay. Um,
Okay, does it sound like you can hear me better now?
yes, yeah, that is better. I don't know how long this is lasting. It looks, I don't know.
I think they said it's like 20 minutes. So I guess just
Oh,
looking at the
wow.
case study.
Okay.
Yeah. Looking at the case study and then kind of discussing what went right and what went wrong. And, sorry, yeah, I think it should be better now because I'm not like driving on like the, well, at least for now.
Oh, okay.
Driving where it's not so hectic, but it was also just raining really hard. But yeah,
Yeah,
so I guess we are just talking about the case study. They also said that they made like a chat because I forgot the exact questions, but I think they were saying like what went wrong.
I know. That's what I was looking for too, and just to like review it because I do better if I read it, and I was trying to finish it, but then they put us into groups. But there's supposed to be 2 other people on here. I don't know if they are involved or not, but
Let's see. Oh yeah, it looks like there's 4 people on here.
yeah. I mean, it's just such a hard one. I guess I would hope that there would be like an advocate at the hospital that you could reach out to instead of just leaving. So I think if you leave, then there's other, legal things that come in to play. But I don't know. I don't know that that's always an option in hospitals. I
Yeah.
know.
You know what? Sorry.
Oh, a friend of mine who brought their child in had one child who was having like struggling with mental health, and then a baby who had a concussion because they were injured by the older sibling. And she was like, I have to take my baby home. And then she got in trouble for leaving. And it's like, well, I don't know. It's the system is kind of it's a struggle, right? To do what you feel is right for your family or for yourself or your child. And then, um, there are sometimes repercussions of that. But
Yeah, that's really sad. And
I
yeah, I was like, I
know.
don't know if that is really possible for like an advocate, but that would be a good idea. I mean, at least like I mean, I'm just kind of in this link thing because my coworker had sent it and said, "Oh, it could be good information to learn." I was like, "Okay."
Yeah.
But anyways, because I know when we're at a social services organization. But
Mhm.
beforehand, like I did work in the hospital. Like I worked in the emergency department. I also worked as like a tech, like an inpatient.
Oh, okay.
Right. And I feel like it was very challenging in the midst that a lot of them just didn't feel like understood. And I really think like that's just like really the major component. People just want to be heard, they want to be understood, and then coming to a place where no one's even coming to like hear your situation or like thinking that they know the situation. Well, they don't know the extent to it. But like taking
Yeah.
that time to actually like get to know and hear their side of the story to understand like, oh, why did this happen. And then maybe look
Yeah.
at resources that can help mental health wise, and preventing, and maybe something like that is like, oh well, that's not really like a good thing to do. And it's like, yes, but to give them support where they can like understand that. And I think that's just in the midst of really coming to really be solidified in those different in just the different mental health resources that can help them.
Yeah.
And then I guess just I know one was like what went wrong, and I guess just in the hospital, well, they didn't really take the time to listen, and they were like talking bad, they were complaining. It's something I noticed too, though, from working in the hospital is like a lot of like nurses and clinical staff I worked with would always complain. Always. It was just crazy to me. Um, so,
Yeah, I remember, like, I've been in the hospital quite a few times, mostly children's, but it
yeah.
was always surprising to me to hear the staff and nurses, kind of griping, because I just thought, oh my gosh, like you should be doing this away from patients, maybe. And
Yeah.
I mean, all hospitals are different, though. I really like how Seattle Children's has like signs on the doors where it tells you what language the family speaks.
Oh, that's smart.
Um, yeah, it's really helpful, right? But I mean, I think unless it's like a mandatory thing, I think it just really depends on the facility or the state or even the county, um, what they say needs to be provided. And at Children's, they have, I forget what they're just like social workers that you're assigned to that help you navigate things. But if that wasn't an option for this person, then yeah, they'd have nowhere to go to. And it really does sometimes depend on just the doctor or nurse. I know when we're inpatient, it can be the best 4 hours and then the worst 4 hours because there was a shift change, and um, and it can be incredibly frustrating because you're told one thing and then the next doctor or nurse comes on and you're told something else, and the plans change because maybe they disagree with each other or whatever the case may be. But it is incredibly frustrating as a patient to have to deal with that.
Yeah, to kind of see more of like a plan. But I do like that how they like will actually put in the door of like the language they speak. That it sounds like
Yeah.
it's like neglected a lot, and then it's just challenging. Oh, like,
Yeah. Well, I work for the ARC of Snohomish County, and we have a translator line. So we're able to use that to talk to families with that speak a different language. And I mean, it's not the best, but at least there is that option. We don't always have to find somebody, that speaks that language necessarily. Um, But if you don't know about that resource or your organization doesn't have access to that resource, then what would you do? I don't know. It's just so frustrating.
yeah, yeah, and
Um,
I know like our organization also has like some kind of translator service. Which one it is, I'm
mhm.
not for certain.
Yeah, I'm
But
forgetting the name of it, but
yeah, but I do know like one thing they've struggled with a lot has been like Portuguese or Portuguese. Yeah.
oh, yeah. Oh, I think it's just called the language line. That's my understanding. Um, but I think you have to I don't know if we have to pay for the service, but I know that we have to like register and stuff. So it's not just open to anybody.
Yeah.
Um, Yeah. I don't know. I mean, do you live in the Washington state or are you out of the state?
I live in Washington State. Yeah.
Oh, okay. I just wasn't sure like how many, if this is just everyone, in the same area, or it's always hard on Zoom. I never know where
Yeah,
people
I
are
know
from.
that's true. Yeah, I'm not really sure. I mean, I just know that it was like an external sort of thing, but that my coworker had told me about this, and just yeah, it's
Yeah.
good information.
Well, I wish they had put more people in the group. um, it might have made it, or at least if the two people were participating that are here. But yeah, I feel bad. Like I said, I kind of missed part of the story because I was trying to read it while she was reading it, and it was just hard to focus. And then, um, but yeah, I guess it's just, I would say it's just policy. Policy has to change, and but then it's also difficult because when organizations are low staffed, um, you can put all the policies in place that you want, but if there's not enough people to follow through, and then you get good nurses that are just or doctors that are totally overwhelmed with everything they're supposed to do and they don't have support, then they might leave and
Yeah,
then it's an even worse situation. But I don't know.
and I think that's like a big thing too. It's just the whole laughing issue. But I think it's good, kind of what they discussed here though, is like really kind of having something where they can have, for example, the organization we're part of like has something called the DEI committee, which is diversity, equity, and inclusion
Mhm.
committee, and we kind of just talk about for what the eyes that we see, issues that we see, and we kind of bring that to light about, different things you change.
Yeah.
We can like, better do that and then check with like yeah, I think they were mentioning too, they were mentioning something about even talking to like past participants who were here, and even hearing like, hey, like how was your experience, when you were with us, like did it feel like
Mhm.
that, you felt included, or like did it feel difficult, and I just even asking the questions.
Mhm.
Um,
Yeah,
because
we've
I think
we've had that kind of training too. Um, I think part of the struggle too can be, I like what you said about, reaching out and seeing how the experience was. A lot of times we get really defensive when someone has a complaint, when you can really learn from that. And so maybe if someone calls in with a complaint, be like, oh my gosh, like we have this, DEI board. Would you like to participate and to share your story so we can learn, as opposed to, just getting defensive and kind of shutting them down. So much of it is listening, especially for me. I mean, I'm a white female that's lived, on the east side most of my life. And now I'm in North Seattle. I haven't had to deal with, you know, these issues just because of where I live and what I look like. And so I have to learn from others. I want to hear their stories. And it can be hard sometimes when, maybe they're feeling angry or frustrated that I don't understand or can't relate. And it would be really easy to just get defensive and, shut down. But I really try not to, and to say, I'm sorry you feel that way.
yeah,
I'm here to listen, I'm here to learn, but I'll never be able to know, I'll never know your experience. And sometimes I feel like in order to support, you know, individuals, especially minority groups, I have to listen and learn to to others because how can I support them when I can't, when it's, I never lived that experience, or um Yeah, so maybe just better training. Maybe that's it. Just the hospital having, the DEI training um, and having that information.
Yes, exactly. And to come to a place where, yeah, we have the information, like maybe you said, like even some meetings, that can come and, where we can be like, maybe like there's surveys or something that get passed out and be like, hey, this is like the experience I've
Mm-hmm.
had. It's like, okay, well, why don't you invite your experience to share, with the DI committee, so we can have more of like an understanding, because I
Mm-hmm.
think a lot of people will try and think that they're thinking DEI and they'll go through all those, but I mean, the way that it is, at least for us, it's like, oh, let volunteer or say if you want to be a part of it, It's like, oh yeah, we
Yeah.
do. And you'll have those like select few that actually do genuinely want to be a part of it, and from the midst of that, they can then come to a place of where they can hear what they're saying and feel like it can be a safe
Yeah.
spot. Because now you have people that are all in agreement that hey, this is what we want to do, and we're here to help you. That's why we have this. We chose to be a part of it, and we want to hear their experience because we want to do better.
Yeah.
There we go.
Oh,
Oh, we have more people now.
oh,
Hello.
is this
And we're
back
back.
to the
Oh
Oh,
full?
goodness, we're sitting in a.
Back down.
I
We're
hadn't
at
seen this.
Is this back to the full count then?
oh, okay. I'm going to turn my mic off. I hear some weird sounds coming in.
okay. Am I sharing? Not sharing anymore.
No. I really love this audience screen where we're like sitting and like, I'm like this is so silly. I love it.
All right. I think we're back. So you should see the slides up with the questions.
Right.
Can you see that okay?
Yeah, yeah. I think
Yep.
we lost a lot of folk when we went to group. It looks like we have 15 people, so we lost about half.
Yeah, at the beginning, it just had me in one, like a group with myself. I had to log out and log back in to the meeting.
Okay,
So maybe that's why.
maybe. Yeah.
So
I'm
Well,
we
thank
hearing a
you.
lot of
Thank you
weird
all.
sounds though. Maybe if everyone could mute their mics. I'm going to do that now too, but
right. Well, yeah. Technology is not always our friend, but I'm so glad you stuck with us. The ones that have stuck with us, I think people might be um, logging back in. Sometimes that's the strategy to get back on. So I'm gonna just turn it back to Maylene. We're gonna just talk a little bit about what that was like for you all and see what you guys came up with from the questions.
Yeah, thank you, Kima. So we have about 7 minutes left to our time together before we end. So we would love to take this time to hear any thoughts that you would like to share. Maybe drop them in the chat or any questions that you might have. We also wanted to share that when we send out the PDF for the presentation, you're going to see some questions and some recommendations that Kima put together for us of like questions that you can ask as a provider, questions that you should probably always ask as a provider, and some continued considerations and resources. So you'll have that. Um, at the end of our time today. But yeah, I'm a little curious. Let me go back to, sorry if I switch screens and I don't see you. I know we've been a little bit of a quiet group and this has been mostly didactic presentation, but I would love to see if there's any thoughts or questions. I could be long-winded, so I don't
I
want to
can
like,
share for my group, but can I just verbally share it as opposed to typing in?
yes, please.
Is that okay? All right. So regarding question one, reflect on the barriers that she experienced and what happened. So we listed was that we don't know if there was consent. So was she asked about touching her, body and being in that space? We shared that they didn't validate her concerns or identify maybe her lived experience was different. They didn't promote self-advocacy, so they didn't promote her speaking up for herself. They were kind of shutting her down when she did speak. We don't know if she had continual care. What was her, pre-existing care like? What was the doctor like? Was the care coordinated? They didn't provide any sort of education, and they made the assumption that she understood cognitively everything, and made her feel less when she didn't understand, which would drive up anxiety in a person. It doesn't look like they took everything into consideration. I have quick hand notes, sorry. They were rushed due to maybe their circumstances and the urgency of the baby. We talked about maybe the hospital setting was really rushed and they were looking from their angle as opposed to focusing on mom and what her experience was. And then for question 2, identify the social determinants and the mental health factors, was that the situation was urgent. It could have had a risk to the baby. The baby was the focus and not so much mom and her lived experience. Mom was in crisis and maybe there was a difference in how they could have handled that situation. There wasn't a slowing down period. It was very kind of quick. Our society is quick and get it done. What reflective process does the team have? How are they navigating the situation? And then factors. Question 3, they didn't level out the playing field. So, there was a bunch of them and only one of her, and they didn't identify that she may have felt like it was too much coming at her. And we discussed that, there was an urgency with the baby, but regardless, it was taking the same amount of time. So it would have benefited them plus mom to slow down and just kind of make sure, like, why is your family calling around to these other, clinics? Because maybe mom's thinking that these other clinics, if she gets into them, won't have to do a C-section. And maybe if they just took the time to educate her, she would understand, okay, I'm gonna have a C-section regardless, that this is not based on where I'm located. Because maybe families like, well, we'll call around first to make sure. And there's just a lot of people jumping in to try to help. And maybe it's not so helpful for the mom because nobody's including mom. Everybody's trying to make decisions for mom.
Thank you, Jessie. Oh, I'm sorry. Were you going to say something else?
Nope. Just trying to find my mic to turn off.
Yeah. Also, like, we were wondering in my group as well if, like, considering the overwork and burnout of the system, right? And wondering if the different providers that were coming in, if they were having an opportunity to hear about this high risk case and to consult before switching gears, to think about the implicit biases that might have been in place, as you think about like a 45-year-old birthing person who is Black, who has HIV, whose family is there asking questions. If instead of seeing the family as partners, are they seeing the family as problematic? And I also like what you brought of like, was the family actually partners and helpful? Or, was there something going on? Was Barbara like, no, leave me alone?
And I shared an example when we were doing it, only because I didn't hear anybody else. If anybody else wants to jump in, please feel free to cut me off. But I shared an example. I have a 17-year-old son who is medically complex and fragile. So he uses a wheelchair, has a degenerative disease. And so when my 10-year-old was born and I had a C-section and they said to her, she's not breathing, we're going to put her in NICU, I flipped out. I mean, irrational. Like, they're like, ma'am, we're going to have to sedate you. And I knew they thought, like, this lady's dramatic. And it wasn't until I was in the elevator finally, my husband had come a few days later with my son, that the doctors looked at me and they go, oh my gosh, it made sense. All of a sudden, they're like, this woman's been through some trauma. And for her, in that moment, because my son has a disease that can vary, and in that moment, because he was born breathing, I thought I was going to lose her. I thought she got because I knew there was a 1 in 4 chance that could happen, which is why her name is Chance. But anyways, it just goes to show that, you don't always know a person's story and what they're going through. So what seemed irrational to them felt completely rational to me.
Yeah, absolutely. Thank you, Jessie. And I'm looking at the time. We're at our last minute. We want to thank you for being here with us. Like we mentioned, we're going to send the PDF of our slides. We're also going to send a couple of other resources along. And I'm grateful. Thank you for bearing with us with technology. This is our first time using Teams, like Kima and I, for a training. And so thank you, thank you, thank you. Kima, anything you would like to share?
I am just so in awe of, I got to be in a couple of groups, and I'm just in awe of how well you guys just took on this case study, which is very complex, and you just brought so much compassion, and a great lens for what we need to do to make some change. And it was so great to hear. So I wish we had more time, but yeah, like Maylene said, we'll share those resources with you. And we really hope that this has been enriching and can really help, further the practice that we all need to be doing, which is anti-racist work, right? So that's all we have. We thank you so much.
Take care, y'all. Have a yummy dinner.
Bye.
Bye.
Thank you guys so much. Really
Thank
appreciate
you.
you being here.